Thank you. I'd like to thank the organizers of COLDA for giving me the opportunity to speak with us today. I'll be speaking on the impact and opportunities of COVID-19 and hepatitis. First, we will briefly cover the impact of COVID on hepatitis programs. Then we'll talk about some areas that we can leverage to try and build back better, looking at the expanded capacity of lateral flow assay manufacturing due to COVID-19, the expanded molecular capacity in country due to COVID-19, and the expansion of self-testing through the recent WHO recommendation on hepatitis C self-testing. So to start with the impact of COVID on hepatitis programs, there has been a sharp reduction in hepatitis diagnostic services. So prior to COVID-19, only 1% of those living with hepatitis in the Afro region had been diagnosed. And unfortunately, COVID has really impacted hepatitis testing for both hepatitis C and B. And a survey that was conducted among hepatitis service providers, 27 which the respondents came from the African region, hepatitis service providers reported 90% had experienced a decrease in hepatitis C screening during the COVID period. Likewise, those hepatitis service providers reported 76% of them reported a decrease in hepatitis B screening patient volume during the COVID period. Another paper looked at the number of new cases for hepatitis presenting for hepatitis services from January to April 2020 and compared that to the data of people attending for hepatitis services as new cases from January to April 2019. And what they found was significant decreases. A 71% reduction of new cases in Burkina Faso, 95% reduction of new cases for hepatitis in Tanzania, and 83% reduction of patients presenting as new hepatitis cases in the Gambia. Similar to the reductions in diagnostics for hepatitis, there have been real critical disruptions in treatment interruption and delays for hepatitis. Now, that same survey found that there was a significant disruption in hepatitis C treatment patient volume. So the hepatitis service providers reported 88% experienced some disruption in hepatitis C treatments. Likewise, 80% of the service providers experienced at least some disruption in hepatitis B treatments. And there was treatment reductions in the 2020 period compared to that same period in 2019, 73% reduction of treatments in Burkina Faso, 77% reduction of treatments in Tanzania, and 89% reduction of treatments in the Gambia. So what this shows us is that there is a severe disruption of people who need hepatitis B treatment, and their hepatitis B treatment is being disrupted, as well as potential delays in treatment initiation for people hoping to get treated for hepatitis C. And then we have some other overarching impacts of COVID on hepatitis programs. For hepatitis B vaccination, there's the interruption of routine immunization programs. There's more home births, which is affecting the delivery of birth dose. And then we also see this growing vaccine hesitancy and uncertainty around vaccines in general. And then likewise with the aspects around transmission. Now, there is a positive side in that the social distancing and movement restrictions may decrease opportunities for transmission. However, the disruption of antenatal care is leading to an increased risk of vertical transmission. And the disruptions of harm reduction programs are leading to an increased risk of transmission of hepatitis C because those harm reduction programs aren't able to provide the normal services. So what's these underlying causes of the disruption? So from the demand side, from the patient side, there's a fear of attending health centers. There's the movement restrictions. So even if recipients of care want to go to the health center, they may not be able to. And then there's economic downturn, right? So the economic downturn impacts purchasing ability. So people may not be able to pay for hepatitis testing and treatment services. Then from the supply side, we see that many health workers have been redeployed to face COVID-19. Health facilities have been devoted to COVID-19. In some cases, entire hospitals are converted to just deal with COVID-19 patients. There's been supply chain disruptions throughout the world, and funding has been diverted from other health programs to COVID. Okay, so now we've just given a high-level overview of some of the disruptions of COVID on the hepatitis programs. Now, what are some of the ways that we can leverage what's going on to try and help us build back better? One of the ways that we can think to leverage is the expanded lateral flow assay manufacturing capacity. So we know that in response to COVID, manufacturers have dramatically increased their capacity, mainly for the COVID antigen tests. Now, what we see here on this graph is the total capacity has increased over twofold, 2 times, and it's expected that the order volumes are going to quadruple in low and middle income countries by 2022. What we also see here is that even with the expected orders for the COVID tests, there is still an existing space, an existing new capacity for lateral flow assay tests in general. And the question is how can we leverage that to improve lateral flow assays for hepatitis and for other diseases? One of the ways we can leverage on this increased capacity and has been going on is the increased availability of diagnostic manufacturing within the global south. Now, we know a problem that we faced with COVID is that the lateral flow manufacturing capacity is isolated to a few geographies, right? So mostly in the global north, some in China, and some in the Asian region. But it was not widely or equally dispersed throughout the globe. So through technology transfers, FIND and Unitaid have been working together to enable diagnostic capacity in the global south. One of the ways they've done this is through the tech transfer from Mologic and BioNote to Diagnostics, which is based in Senegal. And the other way is through a tech transfer from DCN to Wama Diagnostica, based in Brazil. So by expanding this, then the idea is that tests can be manufactured locally and distributed quicker. There's also an increased availability of diagnostic development, right? So there's been a lot of work now on the creation of combination tests for COVID and influenza A and B and RSV. So the question is, how can we leverage this for further development of combination tests that include hepatitis? How can we leverage this, really importantly, for more hepatitis B surface antigen RDTs? This is really important because we only have 3 WHO pre-qualified hepatitis B surface antigen RDTs at the moment. And that's the first step. That's the entryway for a patient to get into hepatitis B care. And lastly, how can we get more quality assured hepatitis C antibody self-tests? And I'll speak a little bit more about the hepatitis C self-tests in a moment. So we also have expanded molecular footprint, right? So we know through PACT, the Partnership to Accelerate COVID-19 Testing, which was launched in April 2020, an initiative of the African Union and Africa CDC. The goal is to scale up testing for COVID-19, to continue training healthcare workers on the continents, to establish a platform for pooled procurement at Africa CDC, and to deploy 1 million community workers. So the idea is this pact can, of course, immediately address COVID-19 issues, but then be leveraged for greater health system strengthening as a whole, which we can leverage to expand hepatitis testing. Now, building on the pact, we know that diagnostic capacity for COVID-19 increased from 2 to 43 countries in Africa just between February and April of 2020. Now, this was done in some cases through using existing machines, such as in Nigeria, the Nigeria CDC activated existing high throughput and near point of care machines, activated those to be switched from the HIV and TB testing to the COVID-19, and also by increasing machines. In Ethiopia, they increased the capacity from 0 labs to 65, with the ability to conduct over 18,000 tests a day in just 10 months. Now, while this expansion has been significant, there still is issues of equity, right? So the 8 top testers in Africa account for well over 50% of all of the testing is done. So as this capacity is expanding, we do also need to think about how we can help to have it expand more equitably across the continents. Now, what do we need to do for the, oh, and here we have more point of care devices, right? So we know that the Gene Experts devices, the placement globally has increased 40%. So 40% more machines are out there just in 2021 alone. And we have new up and comers like the TrueNat platform. Now, this has been placed extensively throughout India in relation to COVID. And both the Gene Expert and TrueNat are able to do a variety of different disease testing: tuberculosis testing, HIV, hepatitis C RNA, hepatitis B DNA. So the idea is, how can we leverage on these platforms that are being put out there for COVID to use them for hepatitis C RNA and hepatitis B DNA, as well as other diseases? What do we need to do this? Well, it's critical to document the experiences. So if you and your program in your country are using these platforms which have been installed for COVID for hepatitis or other diseases, we encourage you please to write it up and get that out there so others can learn from you. We need to understand when the COVID-19 situation allows for multiple disease testing. We're going to be going through different waves and different periods. When will there be spare capacity and when won't there? It is going to require country-specific planning and cooperation between agencies and disease programs. We're going to need clear guidance from funding bodies that multiple disease testing is permissible on these machines. And we're going to need best practices compiled by normative guidance agencies. So lastly, I'll quickly touch on the expansion of self-testing, hepatitis C self-testing. Now, recently at IAS in July, WHO launched the first ever recommendation on hepatitis C self-testing. You can go to their website and find the recommendation, as well as a bunch of supporting materials, videos of a community perspective, and all of the information that went into making that recommendation. And just some important points to highlight when we talk about self-testing. When we talk about self-testing for hepatitis C, we are talking about hepatitis C antibody testing. So this is the first steps that you would need to know if you've been exposed to hepatitis C. And it's not here to replace other testing modalities from which the majority of the population learned their status. Now, remember, we were saying that one of the key reasons for the demand side interruption in hepatitis services is people being scared to come to the facilities or not being able to come to the facilities because of movement restrictions. So by enabling people to perform a hepatitis C self-test, we may be able to increase the numbers of those who are tested, even within this COVID time period when there are these movement restrictions and et cetera. And it's not a definitive test. It is a first step to knowing a status. All positive hepatitis C self-test results should be confirmed using the national algorithm. And it's currently research use only. There are no hepatitis C self-tests available yet on the market. We are hoping some of the manufacturers are going through the process, or the regulatory process now. And so we do hope that by next year, we'll have some tests on the market. So the WHO made their decision to recommend that hepatitis C self-testing should be offered as an additional hepatitis C testing approach based on a wide variety and depth of evidence. You can check all of that out in the WHO recommendation itself. But a quick synopsis of the evidence. We saw a very high usability of the oral fluid and the blood-based hepatitis C self-test in the general population when an in-person demonstration was provided before the testing, even among those with no formal education. The majority of MSM and PWID participants conducted the critical steps correctly, and we observed high acceptability of hepatitis C self-testing across 6 of the 7 countries. In China, the acceptability was not as high as in the other countries. Now, when HIV self-testing was recommended, that was in the context of a robust HIV service network, right? There was a clear pathway to those who wanted to get onto ARTs to do so. That's not always the case with hepatitis C. In order to understand this better, we are looking at evidence on uptake, linkage, and cost in Georgia, Malaysia, and Pakistan. And we understand that there are other groups that will be looking at hepatitis C self-testing in West and South Africa. So we are very keen to hear the outcome of those works. I'd like to thank you for your attention, and I'm keen to answer any questions.